Brandon Hayes, who will speak on congenital heart disease in the high-risk newborn. Dr. Hayes is a pediatric cardiologist. He received his medical degree from Columbia University College of Physicians and Surgeons. He completed his internship and residency in pediatrics at the University of Minnesota, and he completed his fellowship in pediatric cardiology at Cincinnati Children's Hospital Medical Center and served as chief fellow from 2014 to 2016. He is board certified in pediatrics and cardiology and is currently an assistant professor of pediatrics in the section of pediatric cardiology at Wake Forest University School of Medicine. So welcome, Dr. Hayes.
Good afternoon. Can you hear me? I'm kind of a loud talker, so I'll try to just talk anyways. Maybe it won't limit me to here, but I guess I drew the short straw of post-lunch talk. So she told me that they were holding the dessert till after my talk. So she said if I catch anyone snoozing, no dessert for you. No, I'm just kidding. So yes, thank you for the introduction. I'm really glad to be here. Just to warn you, there's a lot here we're going to go through, so some of it might go a little fast. I'll be around in the break if anyone wants to talk about anything, but we'll try to get through it, and hopefully this will be helpful for you, at least a review or maybe some new stuff as well. Okay, so congenital heart disease in the high-risk newborn. I have no financial relationships to disclose. A brief outline. So first I'm going to talk about congenital heart screening, which is probably something you're all pretty familiar with, something that we've been doing sort of recently and not previously. Then we'll talk about cyanosis and cyanotic congenital heart disease. That's going to be the meat of the talk, I think. That's going to be most of where we go through a lot of sort of anatomy and different things that go on with the heart and some management. I'll talk about a couple unique patient populations, and then if I have time, which I hope I do, we'll kind of run through some common neonatal arrhythmias, which is also probably stuff you guys come across here and there. All right, so critical congenital heart disease screening. This is sort of a new thing where infants are screened using pulse oximetry, which measures the oxygen saturation in their arterial blood, right? So in 2011, not that long ago, federal health authorities added this to the U.S. recommended uniform screening panel for newborns. And sort of as a background, about 1 in every 500 births is going to have this sort of critical congenital heart disease. Okay, so what are we doing with the screening? We're checking the pulse oximetry in the right arm and one of the legs, and we sort of compare them. All right, and we'll talk about what we look for in that a little bit. But some of the benefits of this are that we can detect critical congenital heart disease early. We diagnose it, are able to manage it, prevent kids from getting really sick usually. We also sometimes pick up other diseases like persistent pulmonary hypertension, sepsis, respiratory disorders, lung problems, other things like this. There are some risks that come with this screen as well, though, because we do get some false positives. So parents are told there's an abnormal screen, they have to go see a cardiologist, they get transported somewhere potentially, they're anxious, they're stressed out about it, and then it turns out nothing was wrong. So good news in the end, but can be, stressful. Another problem with it is that sometimes we don't pick up the critical congenital heart disease even though we did the screen, and even though we're falsely reassured that we're doing well when in the end there is a problem. All right, so I'll let you guys think about this and we'll go over it. So right arm sat of 92% and a right leg sat of 95%. Does this child pass the screen? And number 2 would be a right arm sat of 90%. That sounds low, not going to pass. Right leg is 93. So we recheck it an hour later. It's 92 and 92. Then we check it an hour later. Now it's 99 and 95. Does this child pass? Did I hear mumblings? Yes, no's? No and no. Okay. So the first one actually does pass. It's a negative screen. And the second one actually fails. It's a positive screen. So the one that passes is a 95. You just need to have 95% or above in the arm or the leg to get a pass, and a difference of less than or equal to 3. So it has that. And the fail is you have the 95, but there's a difference of more than 3, and thus it fails. So I don't know if you can see this real well. It might be a little small for you, but this is the algorithm of sort of going through the congenital heart screen. And over here are ones that pass. And so you have to have over 95% in the right hand or foot, and less than or equal to a 3% difference between the right hand and foot. And if any of these happens at any point, it's a negative screen, you pass. And if you're in between that, you basically have to repeat it in an hour. But if it's less than 90 anytime, that's an immediate fail, and they should get further evaluation. One thing I want to emphasize here is this screen really should be done after 24 hours of age. I know we're sending babies home less than 24 hours sometimes, and when that happens, we really need to do this screen kind of right before they go home. We actually just last week had a patient that got transferred to us that they had done a screen around 11 hours of age, looked great, did fine, and the kid ended up having a ductal-dependent lesion and is getting his second heart surgery next week. So that after 24 hours is ideal for this. Okay, so what's the prevalence of congenital heart disease? What are we going to find? So about 5 to 8 cases per 1,000 live births is some form of congenital heart disease. We kind of say 1% sometimes, a little less than that. But a quarter of these can be considered critical, meaning that it's either a cyanotic lesion or a ductal-dependent lesion. So just to give you sort of the most common things, VSD is by far the most common, atrial septal defect more common, is common as well. Tetralogy of Fallot is the most common cyanotic congenital heart disease, and then transposition in AV canal, and hypoplast, sort of a more severe, significant single ventricular heart disease, is pretty rare, but we find these. You'll come across them. I'm sure you have in your practice. So back to the congenital heart screening. Does it really matter which hand we do it on? Can we just do the left hand of the foot? No, we all know why. We'll review it. And can we just check the right arm and the left arm? So what are we looking for? So there's something called coarctation of the aorta. And so briefly, I'll go through the anatomy again in a minute, but this is the aorta, big blood vessel taking oxygen to your body. And it's labeled here as the subclavian artery. This is the left subclavian artery. Over here is the right subclavian artery. So it goes off to the right. This is off to the left. And here, this coarctation of the aorta is happening after the left subclavian artery. So whatever the right arm sees, the left arm also sees. So in this case, you really could do the left arm and the leg, and it would be the same result. However, the coarctation of the aorta doesn't always occur right here. Sometimes it occurs here. Sometimes it occurs here. So it's important to get that right arm because we think that's the one that's not going to have sort of obstruction to flow, whereas if you measure it here and there's a coarctation here, or if there's a coarctation here and you measure the left arm, it'll be the same as the left leg or the right leg because it's after the coarctation. So you won't pick up the difference. Make sense? Okay, so this critical congenital heart disease screening has actually been a really important intervention that we've done in children recently. In a 2017 study by the CDC, they actually showed that states requiring screening saw a 33% decrease in critical congenital heart disease deaths and a 21% decrease in other congenital cardiac deaths relative to states who weren't doing this screen. And now 49 states, including Washington, D.C., require the screening to be done. The only exception is California, which says it should be offered, but you don't have to do it. I don't know who would opt not to do it, but okay, so let's just review normal cardiac anatomy. For those of you who haven't looked at a picture of a heart in a while, this is going to be key for going through the next stuff we're going to go through. So blood flow through the body. So we'll start with the left ventricle, the main pumping chamber of the heart. This pumps red oxygenated blood out the body through the aortic valve, comes up to the head and neck vessels, and then that oxygenated blood, 100% sats, goes down to the body. Your body then takes oxygen out of the blood and uses it for all your organs, your muscles, and everything that's, metabolism that's working. And then blue blood collects in your veins and comes back up to the heart. So blue blood from the inferior vena cava comes up, from the superior vena cava comes down into the right atrium, comes across this valve, the tricuspid valve, into the right ventricle, out the pulmonary valve to the pulmonary arteries, where you breathe in the lungs. Blood goes to your lungs, you breathe, put oxygen from the air back into the blood, and the red oxygenated blood actually comes back from the lungs, the left-sided pulmonary veins. There's should be right-sided pulmonary veins over here coming back to the left atrium. That red blood down through the mitral valve, back to the left ventricle, back out to your body again. Okay, we're all with me. Okay, so let's talk about cyanosis. So there's a pretty broad differential diagnosis for cyanosis in a neonate that appears blue. Maybe not quite as blue as the blue man group, but pretty blue. So there's pulmonary lesions. You can have a right to left intrapulmonary shunt that can cause blue blood to go out to the body and make the baby look blue. Pulmonary vein desaturation, meaning lung disease, so the blood that's coming back in your pulmonary veins is not 100%, it's lower than that because you're not getting good oxygen exchange. You can have CNS lesions causing hypoventilation, neuromuscular lesions, persistent pulmonary hypertension of the newborn. That's because if their pulmonary pressures are very high and there's a patent ductus arteriosus, that blue blood goes from the pulmonary arteries out to the body through the aorta, gets blue blood out to the body. So that causes cyanosis sometimes. You can have cyanosis with a normal partial pressure of oxygen, like methemoglobinemia, polycythemia. You can have congenital heart lesions, like we're going to talk about. You can have something called acrocyanosis, and you can have shock or sepsis that can cause this. Okay, so cyanosis in the newborn. It's not always the heart. So who knows what's going on here? Mumble, 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 not sure. So this is an example of congenital diaphragmatic hernia. So you see all the intestines up here in the chest, not supposed to be there. This is a lung that's all whited out, heart's pushed over to the right there. All right, so recognition of cyanosis. There's the difference of central cyanosis and peripheral cyanosis, or acrocyanosis. So acrocyanosis is a totally normal finding in newborns and even in young children, sometimes in adults. It's sort of vasoconstriction of the periphery of your vasculature, so your hands and feet, sometimes around your mouth, these areas where the end of the vasculature is, has some vasoconstriction, and you can look blue, have this blue-purple appearance. Those of you who work with little babies know exactly what I'm talking about. You see it all the time. This is a totally normal, benign finding. It has nothing to do with true desaturation of the blood. It's just finding of the skin. Whereas central cyanosis can be hard to differentiate sometimes, but it can be very profound sometimes and not so hard too. So for central cyanosis, I'm worried about, is their trunk appearing blue? Is their whole face, not just around their lips? Really, their tongue is a really good one. If their tongue looks really, really blue, purple, that's sort of a central thing. So that's one way you can differentiate that. All right, so cyanosis is a blue or purple discoloration of the skin or the membrane secondary to an increased concentration of deoxyhemoglobin. So that's hemoglobin that's given off its oxygen, doesn't have it anymore. This concentration of deoxyhemoglobin is affected by your overall oxygen saturation, how much hemoglobin you have, what color your skin is, and even what the light looks like in the room. So you typically need about 3 grams per deciliter of deoxygenated hemoglobin in your blood to have the appearance of cyanosis. So let's compare 2 infants with the same saturations of 85%, but different hemoglobin levels. One has a hemoglobin of 20, one with a hemoglobin of 10. So the child with a hemoglobin of 20 will actually meet that threshold of having 3 grams per deciliter, and even though they have the same saturations as the other infant, one will appear blue and one will appear pink. All right, so a question. Audience involvement for a moment. So in the Well Baby Nursery, you're seeing a 12-hour-old boy who's had intermittent episodes of intense cyanosis of the hands, lower arms, feet since birth. The infant appears alert, playful. At other times, his arms and legs are pink, but they have this sort of mottled appearance. He otherwise has been completely healthy. Physical exam reveals no remarkable findings other than the subtle mottling of his extremities. So what's the best diagnostic test for this child that we should do next? Should we consider a Holter monitor to look for an arrhythmia? Should we get a co-oximetry or a blood gas to look for methemoglobinemia? Should we do an echocardiogram to look for congenital heart disease? An EEG that he might be having seizures? Or do we not need to do any tests because these symptoms are benign? I heard someone. E. I like it. Totally benign. This is the description of acrocyanosis, hands and feet that we reviewed. All right, we hit it twice now. Okay, so in a patient who truly is cyanotic or you think is cyanotic, first thing is let's assess it. Let's decide, is this central cyanosis or acrocyanosis? The next thing to look at would be the respiratory status. Are they struggling to breathe? Are they having retractions? Are they breathing really, really fast? Or do they look totally calm and comfortable? Blood pressures can be helpful, especially for extremity blood pressures, referring back to that coarctation look. We can see if the blood pressures differ between the upper extremities and the lower extremities, or between the right arm and the left arm in some rare situations that can be different. And we can also check it, the oxygen saturations in different extremities, as well as if they're on room air versus 100%, if they're desaturated initially. Okay, in terms of a physical exam of these babies, it's really not all about a murmur in cardiac world. So first thing we do is start with the vital signs, look at their heart rate, their respiratory rate, their blood pressure. These can be important clues into what's going on, as well as the respiratory status, the distal perfusion we just talked about, their cap refill, that sort of thing. Are they clamped down? Are they warm and sort of shocky looking? What are their pulses like? Do they have femoral pulses? Can we feel them? Do they have any hepatomegaly or big organs in their belly? Any other malformations going on with the baby? Specific to the cardiac exam, things that I'm listening to are specifically second heart sound. Do you hear that splitting of S2, lub-da-dut, lub-da-dut, or is it just a single heart sound, or is it widely split and always split? You get to hearing these things the more you listen to hearts. Is there a systolic murmur? Do they have a thrill on their chest? Do we hear a diastolic murmur? Any clicks? All these things can be clues as to what could be going on. Other techniques that we use would be, like I mentioned, sort of four extremity blood pressure, which can be really specific if you have a big gradient, but it's not that sensitive. So if they're normal, it doesn't rule out a whole lot of stuff. The hyperoxia test is something that traditionally we've used a lot. I think these days we probably are already getting an echocardiogram before they've gotten the results back of these tests, but in places where you maybe can't get an echocardiogram right away, this can be a really helpful test. So looking at the partial pressure of oxygen when they're on just room air. So if it's greater than 150 millimeters of mercury, generally that means there's no cyanotic heart disease. And if it's less than 100, that's a failed test, and they should get further workup for that. That can be caused by a cyanotic congenital heart disease. Usually then the PO2 is less than 50, and if you give them more oxygen, it doesn't help all that much. But cyanosis due to lung disease may have a low partial pressure of oxygen, but usually does respond to oxygen. So you give them oxygen, it lowers that pulmonary vascular resistance. They're able to get more blood to their lungs, and they actually then can maintain higher saturations, and they respond, and their PO2 goes up. And often a clue to lung disease is that their PCO2 is elevated, meaning they're not ventilating well, so they're not getting rid of that carbon dioxide. And then severe pulmonary hypertension can also, again, cause a failed hyperoxia test with that blue blood going across the patent ductus arteriosus. All right, I still got you with me? We're going? All right. Other things to look at, we'll be getting an arterial blood gas, look at the pH, see if they're acidotic or not, CBC, see what their hemoglobin level is, are they hyperglycemic, hypoglycemic, maybe send a blood culture, make sure they're not septic. And then the key things that we kind of always get working up a kid that we think may have heart disease would be a chest x-ray, an EKG, and an echo. All right, so that's cyanosis. Now we're going to talk about cyanotic congenital heart disease. You all maybe have heard of the 5 T's. You got tetralogy of Fallot, transposition of the great arteries, total anomalous pulmonary venous return, truncus arteriosus, tricuspid atresia. Good cyanotic heart lesions. So you can really divide cyanotic congenital heart disease into 2 categories mostly. One is decreased pulmonary blood flow, and the other one would be sort of increased pulmonary blood flow, although it could be normal pulmonary blood flow and sort of well balanced as well. But sort of that differential, is there not enough flow to the lungs, or is there way too much flow to the lungs, can be helpful. And one thing that can help with that is a chest x-ray. Really looking at the pulmonary vascular markings, you get a sense of, boy, there's a lot of flow to those lungs and they're congested, or they look really, really dry, there's not that much flow to the lungs. We'll show some pictures of that. A right aortic arch is something that can be really helpful in a chest x-ray because it's a higher incidence of congenital heart disease. We look at the heart size, look at the position. Is it in the middle of the chest? Is it in the right side of the chest? How big is it? And then we can also usually get a clue in the, there's a little bit of the belly in the chest x-ray. You can look at where the stomach bubble is, look where the liver is. Is there something called heterotaxy syndrome where situs is sort of messed up and things are all in different places? All right, so looking at that chest x-ray, like I said, we can see increased pulmonary vascular markings or decreased pulmonary vascular markings. So here's an example of decreased pulmonary blood flow. See the lungs are hyper-expanded. You got lots of ribs here, really black lungs, not a lot of fluff in there. They're really dry. Here's an example of a right aortic arch. Here, let's look back one. This decreased pulmonary blood flow has a left aortic arch, kind of comes over here. And this next one you see, you don't see that little knob there. It's kind of hidden behind the spine. So that's suggestive of a right aortic arch. Increase your suspicion, something could be going on. This is called a clog-shaped heart or boot-shaped heart. We've heard of this before. If you know what this is associated with, scream it out. Nobody knows. All right. We're going to learn a lot today. This is called an egg on a string sign. These are kind of things that we learn as cardiology fellows and pediatric residents and stuff, but I think totally appropriate for you guys all to know and to start to recognize, because anyone could be the first one to say, hey, something's up with this. Maybe this kid has heart disease, okay? So this is sort of an egg on a string, called the egg on a string sign. We'll come back to all these, so don't worry that you don't know what they mean yet. This is called the snowman sign. Kind of looks like a snowman. Wall-to-wall heart, that's a big heart, right? You picked that one out. Okay, so first we're going to go through sort of some lesions that have increased, or normal, but increased pulmonary blood flow. We'll do a couple of these, and then we'll do a couple that have decreased pulmonary blood flow. All right, increased pulmonary blood flow. We're going to talk about transposition, total veins, truncus arteriosus, and one example is a hypoplastic left heart syndrome, which is as an example of a single ventricle lesion with increased pulmonary blood flow. Okay, so following an uncomplicated delivery, a 3.7 kilogram term infant developed cyanosis in the first hour of life. Findings at 3 hours of age include cyanosis, heart rate of 140, respiratory rate 56, no murmurs. Pulse oximetry shows 70% in the hand, right hand, 75% in the foot. Then they put him on 100% oxygen with oxyhood, and now the saturation increases to 90% in the foot. Still 75 or 70 in the right hand. Chest x-ray is normal. What's this consistent with? Is this primary pulmonary hypertension of the newborn, pulmonary atresia, transient tachypnea of the newborn, transposition of the great arteries, truncus arteriosus? Anybody? This is a tough one. All right. The answer is this is related to transposition of the great arteries. The key for this is that you have reverse differential cyanosis. So differential cyanosis means that you sort of check the pulse oximetry in the right hand. It was, let's say, 90%. In the leg, it's 70%. So lower in the leg, that's differential cyanosis. Reverse differential means it's lower in the hand, the right hand, than in the foot. So initially it's 70 in the hand, 75 in the foot. You give them oxygen, goes up in the foot, doesn't change the hand saturation. That's transposition of the great arteries. And here's a picture sort of demonstrating what this anatomy looks like and kind of how the reverse differential cyanosis works, okay? So I'll try to walk you through it. So blue blood comes up from the legs, down from the head, into the right atrium, blue blood to the right ventricle. And instead of going out the pulmonary arteries, it now is going out the aorta. So blue blood all through the body. Some of it somehow gets to the lungs, and blue blood and red blood comes back from the lungs. That's getting oxygenated, comes to the left side of the heart, left atrium, left ventricle, and that goes out to the pulmonary arteries. So we need places where blood can mix. And really, in a newborn, the main place it'll start to mix is the patent ductus arteriosus, which connects the pulmonary artery and the aorta, okay? So here you see a little bit of blue blood from the aorta coming back to the lungs, so that's how some of the blue blood is getting oxygenated, and some of this red blood will also go out to the body, which if you give them oxygen in that situation, it sort of did that and caused more red blood to go out to the body down here, and this is usually after that right arm. So the right arm will still be desaturated, whereas the foot will become a little more saturated. All right. This is a picture of transposition in, on an angiogram. This is a cardiac catheterization. This is the catheter coming up through the inferior vena cava into the right atrium, into the right ventricle, where dye is injected. With systole, the stroke volume sends that dye out the aorta from the right ventricle. You can see here's the head and neck vessels, and it goes down to the body. And this pulmonary artery is actually being filled by that patent ductus arteriosus. It's kind of just a cool picture. All right, so transposition. This is sort of an emergency often for little babies if they have this. So this is, we need to work fast. So, and it can be missed in fetal screens. Usually we're picking up a lot of this prenatal diagnosis. This one gets missed, and it can be an issue. So there's often profound cyanosis. There's a question, could it be a large infant? We'll come back to this a little bit, but one reason why a large infant can be associated with transposition is if it's an infant of a diabetic mother. So having diabetes in babies is a high risk for having transposition specifically, as well as other diseases. Usually they're not in a lot of respiratory distress. They're not tugging. They're not really breathing hard. They might be a little tachypnic. There's no murmur. There's a loud S2. All right, X-ray. Anyone remember what this one was? This is the egg on the string. That looks like transposition. That should be the clue there. Okay, so a little quiz. Transposition patient, their sats are 50%. You put 100% oxygen, you start prostaglandins, you watch them, and their sats come all the way up to 55. What's up with that? All right, so the issue here is that the ductus arteriosus really isn't adequate to get enough mixing. The main mixing in a transposition patient occurs actually at the atrial level. So you really need an ASD to mix the blood really well. Sometimes it can mix at a ventricular level, so having a VSD is helpful as well. But sometimes people have, babies are born with transposition and they have no VSD and just like a tiny PFO or a little tiny hole between the top chambers of the heart. And so they're totally reliant on this ductus, and it's just not enough. They're going to be really, really desaturated, and unless we do something about it. So what can we do about it? One thing we can do is called a balloon atrial septostomy. This is where we, in the cath lab, are able to go in, basically put a balloon across the left, across the atrial septum into the right atrium, and just pull that balloon back while it's fully inflated and try to tear a hole up there. This is done when there's severe hypoxemia and acidosis, when there's intolerance to the prostaglandin infusion or it's not doing enough, and to try to increase the mixing by increasing the ASD size. This needs to be done in about 20 to 25% of transposition patients, so not infrequently do we do this. And you kind of get a sense here that when the atrial septum is intact, not a lot of mixing. This is actually normal anatomy, sorry. This is normal anatomy. And then with transposition with a ASD up here, you get a good amount of mixing, and now you kind of have at least purple blood going everywhere as opposed to blue blood going out to the body and red blood going back to the lungs. Here's sort of a cartoon of this. So you can come up through the inferior vena cava in the cath lab with a catheter, put it across the patent foraminal valve, from the right atrium to the left atrium, open that balloon, and then you kind of do a really quick jerk pull and try to tear a hole basically up there. It sounds really aggressive, but it works in the vast majority of cases and helps a lot. Okay, new case. 2-day-old with cyanosis and respiratory distress. So we start with the chest x-ray. Is this a wet x-ray or a dry x-ray? Is there increased pulmonary vascular markings or decreased pulmonary vascular markings? Increased. I think I heard that. Increased. So yeah, it looks wet. There's all this fluff out here. The heart border is really fluffy. You can't really see the borders very well. Okay. This is another angiogram from the cath lab up in the right ventricle. So the catheter comes up, IVC, right atrium, right ventricle, and out to the pulmonary artery, and it's an injection in the pulmonary artery. You see the pulmonary arteries fill, going out to the lungs. And then in the next phase, we see how they come back from the lungs. And when they come back from the lungs, typically they're supposed to just sort of flow back to the left atrium here. But that's not what's happening in this case. It's all sort of flowing back to this confluence and then going around and coming back over here. So this is total anomalous pulmonary venous return. The pulmonary veins are not coming back to the left atrium. They're actually going over to the innominate vein, to the SVC, and to the right atrium. So all the red blood that's supposed to be coming back to the left side just goes to the right side. Needs to all mix again, but this is a reason for someone to be cyanotic. All right, so this is kind of a complicated slide a little bit. It shows the 3 different sort of variations of total veins. You can have basically you have this sort of common pulmonary vein where a confluence where all the pulmonary veins come back to typically, and then this then gets directed to one of three areas. It can either go above the heart or supracardiac, like the picture I just showed, and come back to the right atrium. It can go sort of directly to the right atrium, which is called intracardiac, or it can go below the heart down here to sort of the portal veins into the IVC eventually. And this is called infra, or below infracardiac. The key difference of this is that this infracardiac one is much, much more likely to be obstructed, meaning that the flow from the pulmonary veins will be blocked and it will have trouble getting up to the heart, and thus you'll have high pressure in here and get pulmonary edema and high pressure. This is more of an emergency. Okay? So total veins is the snowman sign. That's the chest x-ray with total veins. Okay, the clinical course depends on obstruction or not, like we just talked about. So they may have congestive heart failure from lots and lots of extra blood flow into the lungs, and you get the increased pulmonary vascular markings like our chest x-ray showed. You'll have a wide split S2. You might hear a murmur with too much flow across the pulmonary valve. You may hear a diastolic rumble with overflow at the tricuspid valve. The chest x-ray has that snowman shine, an increased cardiothoracic ratio, increased pulmonary vascular markings. EKG will show big right side, so right atrial enlargement, right ventricular hypertrophy. This obstructed total veins, the clinical signs are really, really desaturated, they're acidotic, and you give them prostaglandins, it doesn't help because it's not a ductal problem. It's the fact that the blood is not being able to drain from the lungs, and so there's just backup, and you get pulmonary edema. All right, we're still going through these. 2-day-old with cyanosis and respiratory distress. Similar looking x-ray, wet x-ray. This is an example of truncus arteriosus. So this is where the kind of conotruncus in the embryologic fetus doesn't divide into a aorta and a pulmonary artery. Instead, it's just one big trunk. That's why we call it a truncus. That really has both of them. So all the blood comes out both ventricles and mixes with a large VSD, and everything goes through one valve, the truncal valve, and then has a decision of it whether it goes to the body or to the lungs. But as we know, babies are born, their pulmonary vascular resistance is really high, and then it immediately falls. Once they take a breath, it starts falling, and it gets lower and lower and lower. And so as their pulmonary vascular resistance keeps going down, more and more blood flooding the lungs, and less blood going out to the body. So this is a problem. Physical exam, you'll hear a single S2, an ejection click. You probably hear a systolic murmur and maybe a diastolic murmur, which would be that valve leaking. The valves often don't work real well, the truncal valve. The chest x-ray similarly shows increased markings, an increased cardiothoracic ratio. EKG will show RVH. All right, truncus. So about a third of these patients who have truncus will have 22q11 deletion, which is DeGeorge syndrome. Over about a third will have extracardiac anomalies as well. It presents with heart failure, cyanosis, and we really need to repair this early in life, usually in the first week or so, to prevent that irreversible pulmonary vascular obstructive disease from all the blood flowing out to the lungs. So this is an early surgery baby. Okay, another case. We got a 1-day-old infant. They appear dusky during feeding. The oxygen is given via nasal cannula. 2 hours later, baby is noted to be tachypnic, tachycardic, has poor perfusions. Heart rate is high, 170. Respiratory rate, 80 breaths a minute. Blood pressure is 48/30 in the arm and 52/32 in the leg. Looks pretty normal. Pulse oximetry shows 90% while on oxygen. So we're suspecting single ventricle heart disease, potentially hypoplastic left heart syndrome. So this is an example of ductal dependent systemic blood flow. So to walk you through this a little bit, hypoplastic left heart syndrome is really that the structures in the left heart are really, really small or hypoplastic. So the mitral valve is tiny. You often have mitral stenosis or even mitral atresia, so it's just completely filled in. And you have then aortic stenosis or aortic atresia. And the aorta is typically very, very small. And in fetal life, that's sort of okay because a lot of the blood goes through the pulmonary artery, and it's able to go through this, the patent ductus arteriosus, and get blood out to the body, and it even goes backwards to supply the coronary arteries over here. But after birth, if this PDA starts to go away, then there's no flow to the body, and that can be a big problem pretty quickly. So the systemic blood flow is compromised, and you need the ductus to have systemic blood flow. So that's an example of this. So the treatment of this is give them prostaglandins, keep that duct open. And then really they need surgery pretty early on in life, usually in the first week as well or so. They get an aortic arch reconstruction where they basically take this pulmonary artery and make it the aorta, and so the whole body sort of just goes out through a reconstructed aorta. Then there's no pulmonary artery anymore, so they have to sort of form regulated blood flow to the lungs, which they do either through a BT shunt, which is a little tiny shunt from this subclavian artery down to the pulmonary artery here. We'll have a picture of that later. Or they do what's called a sono shunt, which is really from the same ventricular mass out to the lungs. And they sort of make it a specific size and length so that just enough blood goes out to the lungs, but not too much. Okay. Everyone still with me? All right. How we doing? 35 minutes. We're good. Okay, so now let's go through the other part of cyanotic congenital heart disease. I'm going to do less examples of this, but decreased pulmonary blood flow. Okay, so this is tetralogy of Fallot if there's pulmonary stenosis, tricuspid atresia, Epstein's anomaly, pulmonary atresia, critical pulmonary stenosis. These ones with the red arrows are what I'm going to talk about. So you have a guess of what it can only be one of three things. All right, so a child with cyanosis and a murmur. What does that heart look like? Kind of looks like a boot, doesn't it? And that's classic X-ray for tetralogy of Fallot. Someone said it. Very good. All right, so this is another angiogram in the cath lab. You got the catheter up in the IVC, right atrium, right ventricle. Here's the right ventricle. And this is actually the pulmonary artery, very, very narrowed below the pulmonary valve, but blood gets out there. And there's a large VSD, so blood actually goes out the aorta as well. So tetralogy of Fallot has the word tetralogy in it, so there's four things, really four findings. These findings are a large VSD in a big aorta. The aorta sort of overrides this VSD. There's RV outflow tract obstruction, which is at the level of the valve, which is usually small pulmonary valve and pulmonary artery, but also below the valve. You can have sort of this conus or muscle below the valve that sort of obstructs as well. And then because the right ventricle is pumping against an obstruction, you develop right ventricular hypertrophy. And I put up here as this four problems or one problem. And just to give you the answer, it's really one problem. So embryologically, again, sort of that conotrunkus that's developing, it's sort of one big truncus initially, and it's supposed to divide into an aorta and a pulmonary artery. And when it does that, it just misaligns itself a little bit. So instead of making sort of equal-sized aorta and pulmonary artery, it makes a very small pulmonary artery and a big aorta. And then when it's supposed to come down and sort of connect to the ventricular septum, it misses, and so a big VSD is there and leaves us with tetralogy of Fallot and all these findings that we get. Okay, what's the clinical presentation of this? Often it's a fetal diagnosis, but sometimes not. Usually they'll get cyanotic, especially if the duct closes, so you have less blood flow to the lungs than you need. They'll usually have a murmur. That's from pulmonary stenosis, not from the VSD. Again, the boot-shaped heart on the chest x-ray. You'll have right-sided enlargement on the EKG. Rarely tetralogy, so tetralogy comes in lots of different flavors as well, and rarely it can have heart failure where there's really not very much pulmonary stenosis. And either you have a big PDA or sort of some extra vessels. AP collaterals are called aortopulmonary collaterals, or extra vessels that go out to the lungs from the aorta directly. Okay, so another question. You're evaluating a 3-week-old girl. She's known to have tetralogy of Fallot. She's in the NICU, recovering from an omphalocele. She has a fever, diarrhea, poor feeding in the last day. On physical exam, you note prominent cyanosis of the extremities and perioral areas, tachypnea, hyperpnea, heart rate of 180, no murmurs heard. So what's the most appropriate management strategy for this? So we treat her fever and bring her fever down, make sure she's drinking milk, oral fluids, get an echo, place her in a knee-chest position, give her some oxygen, or reassure the mother because the murmur's gone. Anybody? We got acrocystenosis, right? Is that what we described? It's kind of what it sounds like in there. So the murmur's gone. It's great. She's healed. No? No, not so much. So this is a description of a TET spell. So they're really cyanotic, they're really blue, and they're clamped down. You don't hear a murmur because there's no blood going across that pulmonary artery at all. So the thing we can do is actually place the child in what's called a knee-chest position, sort of push their knees to their chest. And what that does is increases your systemic venous return, so your IVC and SVC, really more your IVC, brings all that blood back up to the right side of the heart to try to sort of pop open that pulmonary artery with flow. Okay, so the TET spell is a sudden increase in RV outflow tract obstruction and a sudden drop in systemic venous return. So in this situation, she was really dehydrated, tachycardic. These sorts of things can be instigators of this. So yes, like I said, precipitating events include crying, sometimes just pooping, feeding, waking up. All these things can cause a TET spell. Being dehydrated or tachycardic can really lead to it as well. And sometimes if we start on medications, it can do it as well. So if you give them an ACE inhibitor or sedation, it actually decreases your SVR, your systemic vascular resistance. Blood easily goes across the VSD out to the aorta then, and not as much goes through the pulmonary artery. You get less blood to the lungs. You get less saturations. I love these little Smurfs. They're hilarious. TET spell, sign and symptoms. So a TET spell is like, you're not going to miss it. It's terror. The baby looks possessed. They're afraid. They know something's wrong. And they're not just like fussy. They're possessed. They're going crazy. Really blue. Breathing really, really heavily. Sweating. Murmur? Maybe not, right? You might not even hear a murmur, sort of like we described. So the first step is calm yourself. That's a key one for me as well. I always have to remember that one. Breathe, okay? Number 2, try to calm the infant. You can put them in that knee-chest position. Giving them oxygen sort of decreases their pulmonary vascular resistance, helps blood go through the lungs. Other things you can do is give them fluid. Sort of increasing that fluid, you can try to pop open the sort of subvalvar pulmonary region that's narrowed there. Giving them sedation actually can calm them down and let it get better. Ketamine and phenylephrine increases your SVR. So if you have, that causes higher pressure out here in the aorta. And so if the blood has an option of going here or here, if the pressure is really high here, then more of it will go here. Beta blockers slow the heart rate down and sort of let the blood fill. Then you're not tachycardic anymore. And if all else fails with those things, then you need to have surgery. So this is your tetralogy of Fallot here with a narrowed pulmonary valve, although there's no VSD here, so I guess we're closing the VSD. I don't like this picture now that I look at it. But here's sort of 2 of the surgical options. One would be if they're a neonate, they're a week old, they're having these TET spells, and we need to do surgery. It's usually not great to do a full repair on it. And so they'll often do a palliation with this Blalock-Taussig shunt, which is that sort of vessel or Gore-Tex sort of tube they'll put between the subclavian artery and the pulmonary artery to just allow extra flow to the lungs. Or they can do what's called a transannular patch and really open up the annulus or this pulmonary valve with a big patch there and open it up so that it's no longer narrowed there. Okay, another patient. Look at that chest x-ray. Severe cyanosis in a 1-hour-old infant. That's not normal, right? That's a big heart. Anyone can see that one, right? Another one, same thing. Here's an angiogram of this disease. There's a catheter in the IVC up to the right atrium. This is all the right atrium. Then it gets down to the right ventricle. They put contrast into the right ventricle, but it doesn't go out to the pulmonary arteries. It just goes back into the right atrium. Anyone know what this is? All right, this is all new stuff for you guys. This is good. This is called Ebstein's anomaly. Okay, and this is something where it's called Ebstein's anomaly of the tricuspid valve often, and it's an abnormal tricuspid valve. What happens is normally the tricuspid valve C is a little bit lower than the mitral valve. That's kind of normal, just to be a little bit offset. but in Epstein's it's really offset way down here. This leaflet doesn't, we call it delamination. It doesn't delaminate, so it's a thickened valve. It's sort of adhered to the septal wall here, and it just doesn't work. Blood goes down here and it all leaks back and leaks back and leaks back. So there's sort of atrialization of the ventricle and just a really, really, really big right atrium. It leaks so much that it can't go forward through the pulmonary artery, and a lot of it actually goes across to the left side of the heart, causing desaturation. But that's really, really severe Epstein's, and Epstein's has lots and lots of flavors. Again, you can have it so it's just like a tiny little nubbin of a valve that's doing nothing, or it can be just a little bit down here and actually works pretty well, but you have mild tricuspid regurgitation, and often you can avoid neonatal surgery and just sort of watch those patients. So in treating them, you really want to maintain the PDA to provide that additional pulmonary blood flow initially, and then as their pulmonary vascular resistance drops and more blood is able to get across that pulmonary artery, they usually do better. So it's really an issue right away in life because nothing's going out to their lungs. Okay? All right, another one-day-old infant with cyanosis. Decreased pulmonary vascular markings, dry lungs, hyperexpanded. All right, this one we're going to talk about is called pulmonary atresia with intact ventricular septum. This is another example of a single ventricular heart disease that has ductal-dependent pulmonary blood flow as opposed to the ductal-dependent systemic blood flow. So here you have pulmonary atresia. There's no pulmonary valve at all. Nothing goes across it. Often the right ventricle is very small, although in this disease it can vary a lot as well. This right ventricle can be almost normal size, but sometimes it's really, really, really tiny. Nothing's going out the pulmonary artery this way, so it all goes backwards. All the blue blood has to go across this atrial septal defect to the left side, mixing with the normal pulmonary venous return. Everything goes to the left ventricle. Everything goes out to the body. And the way anything gets to the lungs is through this PDA, the patent ductus arteriosus. So if that goes away, no blood to the lungs, that equals death. That's not going to be survivable. So it's to get pulmonary blood flow, you need the ductus, ductal-dependent pulmonary blood flow. Okay. With this sort of disease, really the clinical findings depend on the RV size and if there are any coronary artery abnormalities. This is a prominent thing in PA-IVS, pulmonary atresia, intact ventricular septum, can have something called coronary sinusoids. We don't really need to get into that, but it can affect the prognosis hugely. There's often severe cyanosis, a single S2 because you're not hearing that lub-da-dub, because there's only an aorta. The pulmonary valve doesn't exist. You hear a holosystolic murmur from that TR often, but not always. Chest x-ray will show a big right atrium, decreased pulmonary vascular markings, and an EKG will have LVH and right atrial enlargement. Really, prostaglandins is the first management, and then really surgery is generally the management that people mostly go with pulmonary atresia, intact ventricular septum, which either means sort of going in and opening up the pulmonary valve surgically, or they might give that BT shunt, a little extra place where they can get oxygen to the lungs, so that connection from the subclavian artery down to the pulmonary artery. And if the RV is big enough and the tricuspid valve is big enough, they can do biventricular repair, but sometimes it's really, really tiny, and they can only just do like single ventricular repair, sort of down the hypoplast region, but it's hypoplastic right heart instead of left heart. But if there are these coronary abnormalities, then heart transplant is often the best option for these babies, unfortunately. You probably have all heard of hypoplastic left heart syndrome, and that's about the worst thing you can think of from a heart disease. I think there's actually good evidence that PA-IVS is worse than hypoplastic left heart syndrome in terms of outcomes. So it's a scary disease. The interventional thing that they sometimes do is you can actually take a catheter and get your catheter right up against the pulmonary artery or pulmonary valve there, and then sort of burn a hole through it. Although this is a risky procedure. I've seen it go poorly where they burn too much, or they cause a pericardial effusion, they cause tamponade, and it can be really messy. So I think unless you're really experienced at doing that a lot, I wouldn't recommend doing that. But a PDA stent is another thing you can do where you sort of, instead of needing them to be on prostaglandins for long term, you can just stent open that ductus and leave it there and let them get bigger and older before you can do a more complex repair. Okay. Review of prostaglandin. I don't know, how many of you have ever given a patient prostaglandin? Got a couple? Great. So this is relevant. This comes up. So who needs them? If they failed that hyperoxia test, if they're ever in acute heart failure or shock, they may, in their early on, doesn't hurt, put it on. It may save their life, make them better. Or single ventricle patients. Sometimes we have prenatally diagnosed single ventricle patients and we know right away they need prostaglandins, and sometimes we diagnose it in the first couple days of life, and that's when we give them prostaglandins. So prostaglandin, the dose is typically 0.03 to 0.1 mics per kg per minute. The key side effects to know about are fever, and if they're febrile from prostaglandin, I'd probably argue we don't need an LP for that fever. If they're apneic and they're being transported to some other institution, we might need to intubate them. That might be a reason to do it. You can get flushing and hypotension and seizures. They might need an extra fluid bolus. Be ready for all these things. This I like. This is an interesting slide. So the effect of age on the response of prostaglandin. So this is a change in partial pressure of oxygen. So a good change of partial pressure of oxygen going up when you start prostaglandin in the first 24 hours of life. And really within the first 4 days of life, you get a pretty good response. But after 4 days of life, there seems to be much less of a response. So it's hard to open it up after 4 days. But after 2-3 days, you often can get a good response with prostaglandin. It's interesting. Okay. Whew. That was cyanotic congenital heart disease 101. So that was a lot. Thanks for bearing with me with that. I'm going to talk briefly about a couple interesting patient populations, and then we're going to do a bunch of EKGs. Whew. This is awesome. All right. So if anyone needs to stretch, do a jumping jack or two, now's the time. We're close to dessert, guys. We're getting there. Okay. So the first patient population I want to talk about is Down syndrome or trisomy 21. We all have patients with this for sure. So we know that it's associated with congenital heart disease, but there's a lot more that goes on as well in patients with trisomy 21. So they have a delayed decrease in their pulmonary vascular resistance. So normally in a patient without trisomy 21, that pulmonary vascular resistance drops robustly in the first minutes of life, but really in the first day or two, really drops down to near normal levels, and it doesn't totally normalize for a couple months, but it's almost normal in a couple days, usually. In trisomy 21, however, this initial drop may not happen at all. It can take days or weeks for that pulmonary vascular resistance to come down, and it may take many, many months to normalize, or it may not normalize really for a long time. They have a 10-time risk of that persistent pulmonary hypertension of the newborn, and they have an increased risk for pulmonary hypertension in general. So if there's a left to right shunting lesion, so a VSD, an ASD, a PDA, in someone without trisomy 21, you're generally not so worried about them developing long-term pulmonary hypertension in the first year of their life. It's reversible. Whereas in trisomy 21, we worry about this a little more. We're a little more cautious and try to repair some of these defects a little earlier than we might if they didn't have trisomy 21. Okay, they also have lots of non-cardiac issues that we know about. Their airways are hypotonic. They can make very noisy breathing. They can have trouble breathing, often just because of these sort of floppy hypotonic airways is the word we often use. They can have intrinsic lung disease where their lungs just don't form normally and they're not perfusing or oxygenating normally. They often are poor feeders. They can be hypothyroid. They can have duodenal atresia. They can have different things. And if feeding or growth is an issue in a baby with trisomy 21, while cardiology probably should be involved and get an echo, I also would recommend ENT, palm speech. All these people should be involved to see what's going on with this baby. So the most common congenital heart disease in trisomy 21 is actually not cyanotic lesion. It's a VSD, an ASD. The AV canal is what you've probably heard of in the study guides. That's the most associated with trisomy 21, though it's not the most common. Tetralogy of Fallot is also relatively common in trisomy 21, but a lot of tetralogy of Fallot isn't really cyanotic early on. And because of this delayed decrease in their pulmonary vascular resistance, so they have high pulmonary pressures, the shunting doesn't happen too much. There's not a huge shunt across a VSD and ASD, and even an AV canal. You don't flood the lungs because that pulmonary vascular resistance stays high. So usually if feeding or growth is an issue in the first couple weeks of life, it's usually not because of the heart. I know I'm a cardiologist saying that, but that's why I really would recommend getting those other specialties involved. And sometimes the pediatrician or whoever's there doesn't really think about all those things, and if the baby's staying where you are, helpful to mention these sorts of things. They may have other issues, but get us involved too, and we'll make the same recommendation. Okay, another unique patient population, infant of a diabetic mother. Everyone comes across this, right? There are diabetic mothers all over the place, and that's great, but the babies often come with issues, especially if it's uncontrolled diabetes. Okay, so complications in infants of a diabetic mother, especially uncontrolled. So macrosomia, large for gestational age, and with this they can get birth injuries, they can get perinatal asphyxia because of this. Sometimes they have preterm delivery. Even though lots of times they're very big, sometimes they have growth restriction in utero. They can have electrolyte abnormalities. Very common is hypoglycemia. They can have polycythemia. They're at greater risk for having hyperbilirubinemia. Lots of things. And the degree of these findings typically correlates with how badly controlled their hyperglycemia was. Okay? The most common congenital heart disease in infants of a diabetic mother is still a VSD. It's most common in everybody, pretty much. But specifically in infants of a diabetic mother, the conal truncal defects are pretty common and make up a quarter of patients who have congenital heart disease and were an infant of a diabetic mother, with transposition being the big one. You may remember when we talked about transposition before, that sort of clue that it was a really big baby clued us in a little bit that transposition could be going on. And that's the big emergency we want to catch, maybe more than the other ones. But these are all conal truncal lesions. You know, ASD and PDA still happen, single ventricle still happens, AV canal still happen, as do everything else. But another big thing that happens is called a hypertrophic cardiomyopathy, or a diabetic cardiomyopathy, we sometimes call it. Has anyone seen this patient before? The infant of a diabetic mother with super thick heart muscle. No one's heard of this? Okay, good. I want you guys to know about this. So what happens is there's cardiac myocyte hypertrophy due to uncontrolled glucose levels. One theory is that this fetal hyperinsulinemia increases the synthesis and the deposition of fat and glycogen in the myocardial cells. So the heart muscle cells get really, really hypertrophied, really, really thick. This can cause outflow obstruction from the left ventricle. So it's sort of like trying to pump the blood out to the aorta, and it just hits a high pressure wall because there's so much muscle in the way. You get this thing called systolic anterior motion of the mitral valve, which also leads to obstruction, and the LV cavity can be very, very small. That's sort of the more typical thing that we see in this. On the other hand, you can also have congestive cardiomyopathy, where that left ventricle is so thick it just can't relax and can't fill, and so the blood trying to flow into that left ventricle just doesn't get down there, and there's high pressure, and so it builds up and backs up to the left atrium, backs up to the pulmonary veins. You get pulmonary edema and have sort of a congestive cardiomyopathy. The good news about this is that while they're in utero and having all this, horrible hypertrophy of their heart muscle, once they're out of the mother, usually this gets better because they're out of that hyperinsulin, hyperglycemic environment, and it goes away most of the time. But in really uncontrolled infants of a diabetic mother, this can be an issue in up to 30% of them. So we see it all the time. This is an interesting echo of a patient I actually had. So at 3 days of life, we got an echocardiogram, and this is what we call a peristernal long axis here. So this is anterior. There's the right ventricle up here. This is the left ventricular cavity. I'm not sure how well you can see this if you're far in the back, but this is the left ventricle. This is the ventricular septum, the ventricular free wall. This is the LV cavity, this tiny little sliver. This is the aorta where it's trying to pump out. This is the left atrium, so coming in to the left ventricle and out the aorta. And then this is in diastole when the heart's at its most full. And then here's a picture of the same heart in systole, so complete obliteration of that LV cavity. You can understand why trying to pump blood out to your body is difficult with heart muscle this thick. Okay, so we followed this baby. This baby was actually had hypoxic ischemic encephalopathy, was cooled. We watched her for several weeks. She ended up needing propranolol to slow her heart rate, lots of sedation, was intubated at times, and got through it, and then came back and was doing well, and we followed her, and by 10 months of age, this left ventricle looks basically normal. So this is sort of what it looks like. And you can see here, so this distance between these white dots here is a centimeter. So this measures, probably, I don't know, 1.5, 2 centimeters almost, just enormous. And here, same distance, 1 centimeter, now it's like, 0.6, 0.7. It's half the size it was before. So it's pretty impressive how it can change, but this can be a major issue really early in their life, and then it gets better. So those you see, the newborn babies, this is an important thing to know about. So management, the mantra is sort of slow and full. We want to avoid dehydration, avoid hyperstimulation. They may need to be intubated. They may need ECMO even if they're not able to get blood out to their body. We slow the heart rate down in the sort of milder cases as well with a beta blocker. Okay. Home stretch, some neonatal arrhythmias. I'm hoping some of these can help you. You guys are the first line watching these babies on monitors and seeing what their heart rate's doing, okay? So we'll review normal conduction really quickly. So there's a sinoatrial node, or the SA node, which is where the stimulus comes from to have a heartbeat up in the right atrium, sends a little signal out, and that signal is actually blocked everywhere from getting to the ventricles. There's a whole layer of insulation here where this little signal comes out and is blocked, except for this one special nerve in the middle of the heart called the AV node that collects the signal and then sends it down through the bundle of His, through the right bundle branch and the left bundle branch, and out to all the little Purkinje fibers so that all the cardiac muscle cells get the signal at the exact same time and they all contract and beat together. Really cool how it works. This is the electrical aspect of the heart. Okay, so normal sinus rhythm. There's a P wave before each QRS, and there's a QRS after each P wave. Normal P wave axis, which we'll talk about. This is really key for EKGs that you need to look at, and it can be hard to tell on a monitor depending what lead you have up there on your monitor. But it's also good to know what a normal heart rate is for age. So some infants, 90 to 175, and as they get older, normal heart rates get lower. Okay, so this is an example of normal sinus rhythm. Boy, those in the back are going to have trouble. The key is looking at the P wave axis, okay, so which direction the P wave is in certain leads. So I don't have time probably to go through into all the little mechanics of this, but a good little cheat is that if it's upright, so this is the P wave. Let's see if I can settle this. P, QRS, T, right? You guys know this, P, QRS, T. So this is atrial depolarization, ventricular depolarization, ventricular repolarization or relaxation, okay? So the P wave here is upright in one and upright in AVF. That suggests it's coming from the high right atrium and going towards the apex in the lower left quadrant, so sort of towards the left foot. And that is sinus rhythm suggestive of, because it's upright in one and upright in AVF, okay? So this is called an ectopic atrial rhythm, and there's two different flavors of this. But we look at lead 1 and lead AVF again, and in lead 1 it's upright, but in lead AVF it's upside down. So this is an ectopic atrial rhythm. It just means it's coming from a different place than sort of where the typical sinus node is. The usual sinus node is in the high right atrium, but this might be in the low right atrium. It's actually a normal variant, but we call it an ectopic atrial rhythm. And when we get to ectopic atrial tachycardia, this is why this is important to sort of have some sense of what this means. Okay, so again, upright in one, down right in AVF. Little zoomed in for you, hopefully you can see. All right, here's another ectopic atrial rhythm where it's down in lead 1. That little tiny P wave is upside down, believe me if you can't see it, and upright in AVF. So this is a left atrial rhythm, suggesting it's coming sort of from the left side instead of from the right side. Again, kind of a normal variant and doesn't cause a problem unless it does. Okay, so here again. Well, this is showing down in AVL, but it's really down in 1 and up in AVF. Okay, so arrhythmia. First is the rate. Is it fast or is it slow? Where is it coming from? Is it coming from the atria or is it coming from the ventricle? And generally, that's sort of narrow complex versus wide complex. So we've got a wide complex that's suggestive of a ventricular rhythm, okay? So let's go through bradycardia. Sinus bradycardia, really, really common. It's defined that the rhythm is originating from the sinus node, so up in 1, up in AVF, but it's just slower than normal. in a newborn or an infant, less than 80 is usually what we are concerned about, but less than 100 may technically be bradycardia. And in an older child, less than 60 would be sort of bradycardic. There's a normal P wave axis, as we talked about. But things like sleep, high vagal tone can cause sort of normal sinus bradycardia, but having a sick sinus node or CNS disease can cause, pathologic sinus bradycardia. Okay, so here's an example of sinus bradycardia. P wave is upright in 1, upright in AVF. It's just kind of slow, but otherwise totally normal. So something called premature atrial contractions. Let's review this. This is also really, really common in the fetus, in the neonate, in children, and adults. Lots of people have these. It's almost always benign, but they're extra early beats originating from the atria. They're almost always narrow complex, but sometimes they're sort of called conducted with aberration, where it was so early that the ventricle wasn't ready to receive the stimulus, and so it went slow through there and caused a wide complex. That can happen. It looks like ventricular tachycardia or ventricular PVC, but usually it's actually more common for it to be a PAC. These are always preceded by a P wave, and 3 PACs in a row is considered ectopic atrial tachycardia or atrial ectopic tachycardia. So PAC, you guys have seen this on the monitors, I'm sure, all the time. It's looking normal, normal, normal. Actually, here's an early one here that didn't conduct, it looks like. And then here's a junctional escape beat. And then here's a really early beat right after that. So see that little change in the T wave? The T wave is nice and smooth here. Here's a little bump in it. So there's a P wave there that came early, and then there's a compensatory pause afterwards. Premature atrial contraction. Sometimes if you have lots of these with these pauses, it makes it look like the heart rate's going real slow, and it may look like bradycardia, and the alarm may be going off all the time. It's not really a true sinus bradycardia, it's PACs. Here's an interesting EKG with lots of PACs. So if you look down here, even at just like the bottom, if you can see it, you just see how irregular the rhythm is. These are regular, then there's an early one, then there's a delay, regular again, delay. It's very, very irregular. And all these red lines here, or red arrows here, are pointing at a premature atrial contraction. There's one here that doesn't get conducted, and then there's another one here that does get conducted. Here's a normal PQRS, and then an early one that doesn't get conducted. Another one that doesn't get conducted. So sometimes they don't get conducted at all. So the atria is making noise, but that AV node isn't ready to get the signal yet. Okay, again, these are really common, don't cause problem, tend to go away over time. PVCs are less common in neonates. They're often benign, but often can indicate underlying cardiac pathology, and probably worth getting an echo if a baby's having PVCs. There's extra early beats arising from the ventricle. It's always wide complex. There's no P wave before it. 3 PVCs in a row is ventricular tachycardia. So here's an example of a PVC. Here you've got your PQRST, PQRST, and then boom, just QRS all of a sudden. There's no P there, and it's wide complex. Then it goes back, normal beat, sinus beat, premature ventricular contraction. And it's happening every third beat. That's called trigeminy pattern. That's actually a very stable pattern, not something that's really worrisome. Babies will usually be totally stable if this is happening. They're perfusing, they're getting blood out to their body. But that's kind of funny. Why is a baby having PVCs? Let's check it out. Okay, AV block. This is when some or all the sinus beats don't go down to the ventricle. The AV node isn't working right. It doesn't see those beats from high up. And it's not that they're coming so early that it can't see it. It's just they're not communicating well. So you can have 2-to-1 block, 3-to-1 block, or even higher block. The most common cause of AV block is damage to conduction system with heart surgery. However, there are a couple of situations of congenital complete heart block that you should know about. If mom had lupus, that's a big risk for having this. And usually when they have lupus, we will follow them as fetuses and see them every couple weeks through the majority of their pregnancy just to check and make sure they're not having heart block. Another thing is heterotaxy syndrome, where the situs can be abnormal. And if you have bilateral left-sidedness, then you may not have a normal SA node, and so that also can cause some AV block issues. All right, so AV block, the signal's coming from the SA node, It's trying to get there, but the AV node says, I don't see you, can't hear you. Okay? This is first degree AV block, where it's not that it doesn't hear it, actually every P comes to a QRS, but it's just delayed, it's longer. It takes longer to get through. There's a traffic jam at the AV node, I don't know. It's going slower. So the conduction is somewhat blocked, but it's not truly blocked, it's just delayed, right? This is 2-to-1 AV block. If we look down here, I know this is probably blocked for some of you. Pun intended. A red arrow, look at this line. So here you see a P wave and a QRS, P wave, no QRS, P, QRS, P, no QRS. So it's 2-to-1 block. There's 2 P waves for every QRS, so only half of them are getting through to the bottom chambers. And this is an example of complete heart block. And if we look at this line here, so here's a P wave that doesn't conduct at all. And there's a P wave here that doesn't seem to conduct because there was a QRS right before it. Another P wave. There's a P wave hidden in here, P wave here, P wave here. And at the same time, the QRS is sort of just regularly going on its merry business. So they're not talking at all. The top chambers are trying to talk and they're doing their own rate, but the bottom chambers are doing their own thing. So these are just, just ventricular, a ventricular rhythm that's independent of the atrial rhythm. Okay, so treatment for this can be giving them Isopril and kind of bringing up their sympathetic tone, but sometimes they need to be pacing. If it's post-operative, they may just need temporary pacing, and it may resolve and get better after that sort of the inflammation from the surgery goes away. But if it doesn't go away, we usually give them about 7 to 10 days. If it doesn't go away, then they often are ended up getting a permanent pacemaker. Okay, we've got 5 minutes to go through tachycardias. We'll be quick. All right, SVT versus sinus tachycardia. So these are going to be helpful things for you to sort of differentiate the two. Sinus tachycardia, the rate is usually less than 220. It can vary, it can, be 180, 200, kind of goes up and down. There's some precipitating factors like they're mad, they're dehydrated, they're hungry, they just pooped the diaper, whatever it is that can cause it. The P wave is before each QRS, and if you give them adenosine, it doesn't go away, it just keeps doing it. SVT, however, is usually a little faster, above 220. It's persistent and unvarying. It'll be sit at 230 beats per minute and almost not move at all. There's usually not fever or dehydration, and often it's hard to see that P wave in the QRS. It's just hidden, or you just can't find it. It just looks like only QRSs. And this does terminate with adenosine. Okay? We talked about this already with sinus tachycardia from the sinus node, but faster than normal. Okay, here's an example of sinus tachycardia. The P wave is upright in 1 and upright in AVF. That's a sinus rhythm, and it's just a little fast. All right. So atrial tachyarrhythmias. There's 3 common types. There's SVT or reentrant SVT. There's atrial or ectopic tachycardia and atrial flutter. So the reentrant SVT comes from an accessory pathway. You may remember I told you before there's sort of this layer of insulation in between the top chambers and the bottom chambers that sort of blocks all the signals that's coming from the top chamber. Well, if there's an accessory pathway, that means there's just a little extra sliver of conduction cells that allow that stimulus to get across from the top chamber to the bottom chamber in a way different from the AV node. Okay, and this allows for an electrical circuit to be set up. So ventricular pre-excitation will happen when there's this accessory pathway, because there's conduction across the AV node and the accessory pathway at the same time, but it's faster across the AV node. So in general, you're in sinus rhythm most of the time. This is an example of ventricular pre-excitation, which means that the ventricles started to get excited a little earlier. There's a slurring of the upstroke. That's ventricular pre-excitation. It sort of looks wide complex almost, although it's not. It's not a ventricular rhythm. You can still see a P wave there. It's still a sinus rhythm. It's actually a left axis, but that's fine. So this is pre-excitation. Wolff-Parkinson-White syndrome is the most common form of SVT in children. It's diagnosed via that delta wave or that slurring of the upstroke that I just showed you. But they also have to have symptoms. So to have Wolff-Parkinson-White syndrome, you have to have that abnormal EKG or that pre-excitation and symptoms, or documented SVT. symptoms being like an older kid might have palpitations, feeling like their heart's going really fast. This can be treated with ablation and sometimes can accompany certain congenital heart disease like Ebstein's, hypertrophic cardiomyopathy, and L transposition of the great arteries, which we didn't talk about, but just in case you ever need reference to it. So reentrant SVT occurs when there's this extra conducting tissue between the atrium ventricles and allows this electrical setup to happen. And what happens is there'll be a premature ventricular contraction and it'll sort of reset the pathway and allow the signal to go through the AV node, and before it gets to all the ventricles, it goes up the pathway and back the AV node again, and it just goes boom, 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 boom. And that's sort of the circuit that gives you the fast heart rate, okay? SVT is narrow complex. The P wave is hard to see. We talked about this already. It terminates with adenosine, or vagal maneuvers like ice to the face, hold them upside down, or electrical cardioversion if we have to. Here's a picture of reentrant SVT. You see it just looks really fast, hard to see P waves anywhere. Okay, so the therapy is adenosine. You need to get a good IV in an upper extremity that's widely patent, and you need to push the adenosine fast, followed by a bolus fast. You need to get that stuff into the heart quick. So that's the key from the nursing standpoint, I would say. This terminates conduction through the AV node, breaks the circuit. It just lasts for a couple seconds, and then they're able to get back to it. The usual dose is 0.1 mg per kg. If it doesn't work, you can keep going up until it does, if you know it's SVT. So here's giving adenosine. You've got this reentrant SVT tacking along. Then you give it, and it kind of delayed, and then it breaks it, back to sinus rhythm. And there's still a delay. You can still see the effect of the adenosine here, but now it's wearing off. The heart rate's coming back a little bit faster. If they're unstable, most of the time they're stable. These babies have SVT. Lots of fetuses have SVT, and babies have SVT, and they don't really know. They're doing fine. As long as they're doing fine, you can give them adenosine to break it out of it or try the vagal maneuvers. If they're unstable, their blood pressure's going down, they're developing a lactate, things like this, that's when we would do cardioversion. And, you know, general dose is 0.5 to 1 mg per kg, up to 2. You put it front and the back or side to side, and make sure you synchronize with the QRS to prevent shocking on T-wave, which can cause VFib, which we don't want to cause. But the natural history of SVT is that about 75% of these go away. Oh, I'm out of time. And some of them come back later in life, and typically medical therapy is only required for the first year of life. All right, I got like 10 more slides. We'll get through it. Ectopic atrial tachycardia. This is where there's a little abnormal pocket of cells that beats really fast. Ba, 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 ba. It's like different from the SA node. It's some irritated little cells that want to make you go fast, and it goes through the normal conducting system. It's narrow complex. The rate can be a little variable, and it typically goes sort of in short spurts. If you give them adenosine, it doesn't really break it. This is a good example of that, and you might see this on your monitors as well. It's sort of like lots of PACs in a row. It's like more severe PACs essentially. But if it's not causing a problem, they're stable, you don't necessarily have to do anything about it. If they're having lots of this, then you sometimes treat it. You can usually treat it with beta blocker or flecainide. Those things will kind of convert them to sinus rhythm and keep them from having as much. And it's something you can sort of watch over time because generally they resolve by a year of age. You usually don't need to have long-term therapy. But if you don't treat it and it's going really fast all the time, it can cause a cardiomyopathy with poor function. All right, last one is atrial flutter. This is when there's an abnormal circuit set up within the atria, and so the atria just keeps beating, ba 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 ba, and not all of it is getting down here. So it's narrow complex. The conduction can be 1 to 1, 2 to 1, or even higher. The atrial rate is often very, very fast. So P waves come in 350 to 450 beats per minute, but the ventricular rate is less than that. This happens in neonates, but also sometimes in older children after heart surgery or in adults. It terminates with electrical cardioversion. Usually if this happens and you convert them with cardioversion, it often doesn't come back. Here's an example of flutter. You can really see it down here. Kind of 2 to 1 here, but it's variable. See, the ventricular rate is quite variable. Sometimes it conducts 2 to 1, sometimes 3 to 1, 4 to 1. Here again, this is like, I don't know, 20 to 1. The atria is just going crazy, and some of it's coming down. So it can be an unstable rhythm and something you need to treat. Adenosine is not effective, synchronized cardioversion. Or you can do, if you have pacing wires or you have the ability to pace them, sometimes you can pace the atrial really, really, really fast to get them out of it. Usually recurrence is rare, like I said. Usually no medical treatment once they're converted back to sinus rhythm. All right, I'm done. These are my kids. I have 3 boys. He's 5, 3, and 2 months now. And that's them being monkeys, so that's what I get to go back to tonight. All right, thank you so much for your attention. I appreciate it. 4 minutes. Not too bad. We finished.
Thank you so much, Dr. Hayes. We have a break now, so we'll start back at 2:30.
Yeah, thank you.
Oh my gosh, 3.
Yeah.